Ethics Untangled is made by the Idea Centre at the University of Leeds. It's a podcast about the difficult ethical questions we face in everyday life. In each episode, I interview someone, usually a philosopher, who's spent time thinking through one of these questions, and we try between us to work out what's going on. Do you know what medical information is held about you? Do you know who's allowed to have access to it? Doctors collect lots of data, often quite personal, about their patients. This data needs to be collected, stored, and shared, sometimes quite widely, so that the patients can receive effective care, but also so that the medical profession can better understand diseases, how they spread, and how to treat them. In the UK, there's plenty of guidance for GPs about what information they can store, who should have access to it, and when. In fact, according to Jon Fistein, a doctor himself as well as an academic looking at the ethics of health data, there's too much guidance, it's too complex, and it's not always consistent. As a result, most GPs don't really understand what the requirements are, let alone patients. We talked about what can be done about this, and why the traditional idea of patient information being kept in the strictest confidence isn't really going to cut it in today's data-driven healthcare context. Jon, welcome to the podcast.
Thank you, Jim.
So we're going to talk about the guidance and policy documents and so on that GPs use to make decisions about how to and whether to share patient information and data, right?
That's right, yes, indeed.
So, I wondered, first of all, could you start by saying a little bit about what your own background is and why you came to this question and thought it was worth looking at?
Yeah, of course. So I'm originally a medical doctor, still am a medical doctor. And I had a slightly circuitous route in my career with legal training, and that took me into the tortuous world of information governance. And working there as a practitioner, it became very obvious there was a bit of a disconnect between some of the guidance, or a lot of the guidance, as I will say, that's being produced by central bodies, bits of the NHS, the Department of Health, and so on, and what was really happening in practice. Yeah. And that was kind of interesting in itself from a practitioner perspective. But because I'd always had an interest in the medical ethics side of things, it seemed like a rich vein to tap from a research perspective as well, really trying to understand, first a little bit about why there was that discrepancy in a practical sense, but also try to analyse some of the principles that seem to underlie the decisions that were either taken by GPs, as it just so happens, doctors more generally. My research, as we'll say in a minute or two, is about GPs specifically, but doctors generally, when they decide to share information or not, and looking at how any ethical underpinnings and reasoning that underpins that compares to what might be in any of this guidance that exists, to see if, perhaps my hypothesis was that perhaps people were coming from different perspectives in terms of the principles that they were trying to apply, which is why they ended up in slightly different places and why there was this disconnect between the guidance. So I suppose, the headline really was, or the bottom line is, it's the last thing I'm saying, now, is that it was sort of born slightly out of frustration that you see a lot of guidance that's out there that doctors are expected to or required to follow, and they don't follow it. Yeah. And the question is really why, because, one of the things is, if this guidance, this body we can explore what the body consists of, this body of texts, I call them normative texts. If they're meant to be normative, that is, they're meant to be things that guide actions to enable people to do what's considered to be the right thing. Yeah. And they're not being followed, then what purpose do they serve? They're not very helpful if they're just sitting there as, bodies of work out there in the universe. Surely, if they're there, purporting to be things that influence people's decision-making and actions, then surely they should do that. Yeah.
So we're not buried the lead there. You did conclude basically that there is a discrepancy here. But I was wondering, and I know this is not kind of within the scope of the research, but you might have a sense of this. Is your impression that this particular area is particularly problematic? Because obviously, like, doctors have to make all sorts of ethical decisions, and there's kind of guidance and stuff that they have to follow in all sorts of different areas. So is your feeling that information sharing is a particularly difficult area?
it's a difficult one to give a sort of very succinct answer to. What I would say is I think it's special in some ways and not in others, if that's not too trite. So the thing that makes it like almost anything else that doctors do at the moment, it was a theme. Again, I'm not giving away the conclusion too much. All of this is obvious because it's almost a starting point as well as the conclusion almost, But when you look at, I think, doctors particularly, but maybe healthcare practitioners more generally, and indeed us living in the world, there's so many bits of guidance about all sorts of things that we need to follow. Some to do with ethics, some to do with just procedural stuff we need to do, and people get overwhelmed by that. And I think that's the bit which isn't special about the information governance bit, I would say, because one of my things that I refer to somewhere in my research somewhere was about people looking at NICE guidance, which is the guidance that GPs are meant to follow around things like prescribing and treatment.
Yeah.
And they did a review printing out what GPs were expected to read in just one clinical area in a year. And it was, not ridiculously large fonts. It was 6 feet tall in terms of, when printed out, and they're expected to know this and follow it, and it changes all the time. So in a sense, this is another example of that. Where it is slightly different, I think, is that things that are more directly related to their, as it were, hands-on clinical practice, I think the GPs are much more, I think I found from the research, they were much more comfortable with.
Yeah.
And much more likely to pay attention, whereas actually somehow the information governance thing was seen as a little bit of a chore.
Yeah.
It was seen as a thing that, particularly among, some GPs, doctors generally, I still work with many of my clinical colleagues. I talk and teach clinical students. It's not a thing which is emphasized in medical education massively. Right. And so it's a thing they're less familiar with.
Yes.
And so they tend to kind of like not really think about it quite on the level they would, if I'm trying to decide, a doctor's trying to decide which antihypertensive medication to give, they've sort of been trained to think about that and how to evaluate it. Whereas there's less training, shall we say, for many on, well, actually, what's the right thing to do in terms of information sharing? What are the consequences of that, system-wide? What are the relationships with the patient?
Yeah.
That might be harmed or strengthened as a consequence of it.
Yeah.
So that's why I think it is slightly different but there are many other things, in that domain as well. It just so happens because of what I've done in the past, I've got particularly interested in the information side of things.
Sure. Yeah.
Mainly, I should say, because using information more widely, responsibly, of course, has a real potential to improve individual health, but also population health. And I think, I don't think being overly kind to the GPs that I spoke to, and indeed, it's also there in the policy, but we'll go into more detail on that, I'm sure. There is that recognition that information should be shared more widely. I think sometimes, it varies from individuals, but some were very keen to share information. They thought that kind of trumped everything. And
right,
definitely the balance between, keep things secret because it's between you and your patient, versus share everything because it's for public benefit. That's where, those are the extreme ends of the tension, if you like.
Yeah. And is this an area of medical practice that looks a lot different from how it did, 20, 25 years ago?
When I was a boy, and that's the thing I know. Inevitably, yes, because, that's one of the things that has made this more and more topical. And that's perhaps another thing. And everybody's going to say this about their particular bit of medicine or, technology generally, but it's certainly true that the way health systems are organized and the way IT is used in health have changed radically. And, it'll be very interesting to see, in a few years' time, the impact of the pandemic, obviously with things much, much more being done with computers and virtually. Yeah. But 20 years ago, most records were on paper, weren't they? So if you wanted to share something, I'd have to either hand copy it out or photocopy it and give it to you or fax it to you. You could only do that, one thing at a time. Whereas now, here it is on a system. And I'm going to say this very carefully because there are security controls, and this shouldn't and doesn't often happen. Potentially, I say that word again, potentially, records are available much more broadly.
Yes. Yeah.
And there are different challenges, for example, in, making sure information remains confidential in that sort of setting, because you can't just lock it in a cupboard.
Yes.
But also making sure, of course, that the information is available as well. So, yeah, there are different challenges.
Yeah.
I think sometimes, that's perhaps part of the issue, that the way people think about information hasn't really caught up with that.
Yeah.
I mean, I would say kind of like, controversially, that a lot of, if not the majority of what, medicine's about is about information. Patient talks to the doctor, the other healthcare practitioner. That's an information sharing exercise. There's, a decision-making process that happens about, let's say, diagnosis, treatment, and so on. Information is at the heart of that, tailored to the individual based on the clinical knowledge and all, the stuff that supports that. And then an action happens, which is, again, mediated by information. I'm going to prescribe you something. I'm going to recommend there's an operation. All that information is at the center of healthcare. Yeah. And it's only really become, I think, really explicit with the computerization, because there it is, it's sitting on that system over there. Yeah. And people think, whereas before it was kind of almost hidden.
Yeah. And also there's the issue, I think in the presentation that I've seen, you said, it's not just a doctor and a patient anymore. It's kind of multi-agency teams, like people working together, collaborating, and the patient might not necessarily know who's, working on their case or whatever.
No, that's right. And there are many sort of difficult questions around that, really, which, sort of setting out some of the problem, really, which is, well, what is healthcare anyway? Now, you can obviously go into all sorts of broad directions with that. But as you say, you go to see your name. I'm not sure I know. I probably think I can remember who and recognise on the street, maybe. Maybe I can't actually. I think they might have changed. Who's my named GP in my surgery? I don't know.
I don't even know if I've got one. I think I've got one.
Actually
went to the GP's this morning, and then I saw
who's my doctor?
Saw a GP who I'd never seen before. And, that's kind of typical, isn't it?
I think I've got a named GP. I think you're supposed to have a named GP. I think it might be different. I don't live where we're recording. I live elsewhere in further southern Paris. But that relationship isn't there, as you've seen. So, well, okay, all the GPs that the stranger that you saw this morning, you're assuming they're a GP, of course. And
absolutely.
There are all sorts of contextual things around that as well, of course. But, you're assuming that they've got the right to access your medical record, and they understand that, it'll be kept confidential and they'll treat it appropriately. You'll assume all of those sorts of things. But of course, if they aren't, quote, your GP, have you explicitly told your GP that you could share it with that strange? Yeah. Strange you probably hadn't.
Yeah.
Or maybe you'd signed a waiver somewhere that said, well, actually, it's shared in the practice. And then, what about the receptionist and the practice nurse? Is it all bound up with your care?
Yeah.
It's not just the lone GP.
Yeah.
And let alone if you need to be referred to hospital, that gets shared, let alone if you need to go into hospital. There are a couple of, authors that talk about the notion of confidentiality, and they say, well, it's completely bankrupt now because, we talk about confidentiality and we talk about, a patient says something to a doctor, I'll keep it in confidence. And I'll return to this, of course, in a minute.
Yeah.
But, does it mean anything if actually that's shared with, 500 people?
Yeah.
Oh, but they all understand what confidentiality means. Is that still acceptable? Yeah, there was this notion, I think it was, as this is an idea podcast, I think Chris, the idea founder talks about, I think it must be an Aristotelian notion necessarily about confidentiality in the battlefield. So it's confidentiality amongst your generals in the tent.
Right.
But does that mean anything if your tent is, contains 4,000 people?
Right.
Or however many, 40,000 people that work in your local health economy? I'm not sure that, people do question that. And that's why that concept, although it's possibly a helpful starting point, it definitely needs some of the parameters that sit around it to be defined very clearly.
Yes.
Otherwise, I've told the patient this.
Yeah.
Or the patient has told me this. And then suddenly they find out that conversation has been shared with somebody they had no idea would be part of that conversation. And that is surely the point about establishing a relationship in confidence.
Yeah.
So you have an idea about where information is going to be shared with. Otherwise, that's
absolutely right. I think, even those of us who don't know very much about medical ethics at all would probably have in mind a concept like patient confidentiality as being something that's really central. But as you say, once you actually start examining what that means in practice, it looks a bit opaque, really.
So confidentiality is it can be hard to define because of this changing, healthcare system and the way that health is delivered, I think, and, the very old, maybe medicine was never quite like this, but where it was a one-to-one delivery almost that, the doctor's like, your vicar or whatever, your trusted in confidence advisor. They'll never say anything under any circumstances. This notion of strict confidence, it's something which was actually enshrined in the Hippocratic Oath, where I think the stilted version is something like, anything that I learn about, of course, the old sexist term man, I will not impart to anybody, whether learned within medicine or without. In other words, if we are being the Hippocratic doctor and you tell me something about your health condition, even though I'm not acting as a doctor right now, then I'm not going to share it with anybody. Now, there are things which still persist. If you tell me something as a doctor about your healthcare, even though I'm not your doctor, and I blab it to somebody else, then the GMC doesn't smile particularly kindly on that kind of thing, because doctors are expected to behave in a particular way. But this notion of not sharing with anybody just wouldn't work, because you couldn't see, you'd have to tell your entire life history to the stranger that you saw this morning. So that's certainly changed. But the other thing that's changed, of course, is the way there's that aspect of healthcare delivery. But also we try to have a sort of science-based medical system. We try to a learning health system, and a system where the quality of care is checked. And of course, necessarily people also migrate through this system over the course of time, where you see a GP in a hospital and another clinic somewhere, whatever. So you've got to keep track of all of that. How much of that is bound up with direct care? This is one of the big sort of debates that's been had and really continues, which is, it's generally accepted that it's kind of ridiculous practically, and indeed, ethically, which we can go into if it's interesting, to say that, okay, if information is central to the provision of care and the patient doesn't give that information, or is unwilling to give the information to the caregiver, let's call them that, then that care can't be given. And so the caregiver's got the right to refuse. So if there's something about your care that, I need to know, I don't want to tell you that, doctor, for whatever reason, that means I could say, well, actually, I can't treat you safely, potentially. And because of the potential implications for me, I should have the right to refuse that, to give you that treatment. Of course, you need to be honest with me about it. That's a whole other thing as well. Because effectively what you're doing is you're saying, well, actually, I'm refusing the care as the patient.
Right.
By not doing that. Effectively, I need to know this. It's like, think of a physical analogy. I need to take some blood from you. Well, I'm not going to allow you to put a needle into my arm. Effectively, they're refusing the care. So I need to refer you to somewhere, but I'm not going to tell you the information that you need or let you share it. 2 steps in that chain. Well, effectively, you're refusing that care then, aren't you? Because I can't make that referral safely. So, there's that. And as I say, so that's bound up with direct care. But there are lots of these activities which I think are rather unhelpfully called secondary uses, which are about, say, checking the safety of care.
Right.
So I'm merrily doing my practice, terribly badly. Probably a patient would want to know that somebody, not me marking my own homework, is checking up on it. And that should be bound up with the care. Because otherwise, how will anybody know that it's safe? But of course, that person has no relationship with my patient. So should they look at that confidential information or not? And there's a bit of a rather uncomfortable position in some of the guidance that's out there at the moment, which is, well, if it's done in a single organisation, so in a hospital, and they're checking up on their doctors in that hospital, that is bound up with the care. But as soon as it crosses organisational boundaries, so, you get referred to another hospital and somebody wants to look at the whole care pathway, that's a secondary use and we can't look at it. So it's all a bit, this kind of muddle is the sort of thing I was trying to sort out. Is there any kind of principle that underpins that? Is it that actually there's a principle in this case of, well, confidentiality, the tent, if you like, extends only to that organisation, and so that is the one limit? Or is it actually that there's an underlying principle which is the most important thing is to ensure safety and care, regardless of the context of it? How do you go about balancing those? And that's kind of the sort of thing I was considering, because almost it seemed that different people would interpret what was out there in different ways. And because of the nature of these normative texts, which I can describe, as I say, well, maybe I will describe in a second, to say what they actually are. They were all written at different times for different reasons. And so they all kind of come up with slightly different views on it.
Yeah. Good. So, I mean, so there's a lot of complexity out there. So it looks like there's kind of maybe the concepts that are being used and the way those concepts are being applied by medical professionals and how things are being communicated with patients looks like it's kind of lagging a bit behind the complexity of what's actually involved.
Ultimately,
in practice,
that's it.
right?
I mean, so a couple of things to say about that. I mean, first of all, the complexity is definitely a real thing, and I did some work not to do this particular bit of research, but some work separately in these things called citizens' juries, where we were looking at. It was all about information sharing again. I'm very much a one-trick pony, in this sort of this dimension about whether it should be shared or not. And the consistent message was, it was supported by other literature in the research there, that people sort of patients wanted information to be shared for good. And they were generally comfortable with it. And, they had various concerns about how it was shared and what it was used. But when you have a conversation with them, actually, when you talk to them first about how information is used for the sort of things I'm talking about, checking the quality of care, or even things like paying for that care and, where it goes in the different organizations here, as we are, I should say, in England, the complexity of the landscape of the organizations, you explain this to them and actually their confidence goes down. And their trust in the system goes down because they didn't realise quite how complicated it was. Now, you can then take them on a journey explaining the safeguards and the uses, that the risks aren't quite as big as they thought and the benefits are quite great and there are safeguards. And they generally end up feeling more confident about information sharing than, they started.
Yeah.
But people don't realise the complexity. So it's definitely, part of the issue there.
Yeah. And so you wanted to go and understand how these decisions are being made in practice and particularly kind of what the guidance is that doctors are using and how useful that is and how useful they're finding it. So you went and looked at what you call normative text. So basically guidance, laws, policy documents, guidance from regulators, things like that.
That's right. Yes.
And what did you find?
So first, I'd say what the normative texts are. I mean, you've kind of outlined what they are. So why did it's a weird term, normative text. It's one I shamelessly stole from somewhere in the literature. I was trying to find some term which was meant to be something which is, as it were, written in, PDF rather than stone these days, that people taking these decisions are meant to have regard to or follow. And that encompasses a range of things. I mean, law is one of the things, and that in itself is complex. All sorts of things, like the GDPR, data protection law that is, and Data Protection Act as it is now, confidentiality law, privacy law, and so on, let alone all of the regulations that govern NHS data use. All that's in law. And then you've got a big body of NHS policy that's out there. Then, doctors were regulated by the GMC, as I've said already. There's guidance there that we have to follow, and local stuff, and. So all of these things in themselves are kind of complex. And what I wanted to do when I looked at the documents was to see they're clearly making assertions about things that should be done. Don't share information for this reason or respect confidentiality. And I wanted to understand where those statements were coming from and what the ethical underpinnings of them were. Say you could take a let's take a consequentialist approach, for example, and say, look, if you don't respect confidentiality, then therefore what will happen is lots of people won't trust the doctor. They won't tell them about their illness, and then public health will suffer. I mean, it's a very facile version of that argument, really. You could go down that sort of route. So are they using any sort of argument at all to say, respect confidentiality, and particularly where sometimes we mentioned, the boundary between what's confidential or not, or when it should be respected or not, which is the big issue, of course. Sometimes the guidance will grade it and say, well, the strictest confidence or in strict confidence. What does strict confidence mean? And it's particularly relevant because if you're saying, look, okay, tell me something, Jim, and I'll keep it in the strictest confidence, probably your expectation as a patient would be, we're not going to share it with anybody. But of course, then you saw the other GP this morning. So that were you disappointed or not, or you then find out that information that you told me ended up being shared with your local health commissioning board or somebody where, one of your wife's third cousin worked and looked it up, get all sorts of failures in that chain. Are you disappointed? I didn't even know. What do you mean it left the GP surgery? So what are these expectations and what do we mean by those concepts?
So there's all this kind of nuance in what, I mean, and confidentiality, we should say, is just one of the principles that you looked at, right? But there's all this nuance in confidentiality and like what the limits of confidentiality are, what we mean when we say something's going to be kept in confidence and so on. And did you find that these documents that you were looking at were reflecting that complexity? Were they overly simplistic? Were they at least trying to kind of reflect the fact that there's a lot of nuance?
Well, clearly, there's a variation between them because they're not all written, as I said, this body of normative text, they were written for different purposes over different periods of time, Before I answer that particular question, think about the GMC duties of a doctor and the guidance on confidentiality is meant to set out at a high level, really, what a doctor is meant to do in order to remain as a doctor. So if they don't behave, then they get, in extreme cases anyway, sent off, And, the law of confidentiality, common law confidentiality was developed over years in the common law. So that did a different thing. It started off about, it's actually Prince Albert and his book of etchings to protect that was the original thing,
Okay.
And, data protection and notions of, privacy, all of these things, they're there to do different purposes for different time, let alone all the complex bits of the NHS,
right?
Related legislation and NHS guidance. So I can't give a simple answer that covers them all.
Yeah.
Generally speaking, by the nature of these things, they start very generally and they say, keep things confidential unless the following things apply. And that's the kind of the difficulty, isn't it?
Yeah. Yeah. And did you find that given, how many different texts there are in there, or what you've just said about, their different purposes and so on, were they internally consistent? Did they contradict each other? Did they contradict themselves? What did you find?
So, of course, it varies. It was mainly a sort of contradiction almost by omission in that there are sort of broad exceptions. Take confidentiality. We talked about it again, keep information confidential unless there's a public interest to disclose that. So you then sort of get into issues about consent for information sharing as one of the gateways. Even before you even get to consent, does somebody want to pitch up to, as we're talking about doctors here, the surgery, and share information, knowing that they will keep it confidence, apart from these other things which are in the public interest that must be shared?
Yeah.
For example, you turn to the doctor and say, I'm going to kill somebody.
Yeah.
And the doctor has a reasonable belief that that's going to happen. They can tell the police and anybody else, I think, to take action. Yeah. But I told you that in confidence, doctor. Well, this is tough, Good that the doctor found out and tried to do something to prevent it, probably, if they did. But actually, would the patient have told the doctor, had they known, they could say, well, actually, don't tell anybody about it. That's an extreme case. But, so I think it's edges like this where a term is used. We're going to keep something confidential, except we're not.
Yeah.
Where it's more, that's a very blunt example.
Yeah.
Let alone the nuance of, well, okay, you're sharing it within, you're sharing it with a doctor for the purposes of care. Then the doctor then takes the decision about whether they pass it on to their colleagues.
Yeah, absolutely.
There are high level statements about that. They're sort of at odds with probably the patient in the street's notion of what these words actually mean.
Yeah.
Now, like I said before, once they think about the issue slightly more deeply, they realise that is what it means. But I suppose, the headline, for this and almost the conclusion of the research is just be a bit more open about it so people can take, informed choices. If one of the principles that, that's out there, Fiona Caldicott, the now late Dame Fiona Caldicott and, the Caldicott guidance, one of the main messages is that people shouldn't be surprised. And if patients are surprised, that is an issue, isn't it? For, in terms of confidentiality, because they should have an idea of where information is being used. And, that sort of opens up another one of those other themes, which is this whole thing about how much do patients need to be informed at the point of these decisions being made about that information sharing itself. And, there are all sorts of interesting questions about that. If everybody knows that, well, like when you go to the GP, you're going to be seen by 5 different people or however many it is, and it'll be shared. Do you need explicitly to say, of course, well, by coming into the surgery today, Dr. Davis, the first thing I'm going to say is, do I have your explicit consent to share information with all the other people in this practice or not? I've certainly never had that conversation with my GP.
No, me neither.
There's kind of an assumption there because everybody thinks that's a reasonable thing, probably. Yeah. And that's, sort of my colleagues actually used to work here in Sheffield, in fact, wrote a couple of papers about this notion of reasonable expectation more broadly. Okay. If you're existing in a health system that has that complexity, surely you would expect people to monitor your care and that there'd be information flows that might have, information about you in it.
Yeah. I don't know. I wonder what people think about this. I suppose my sense is that a lot of people might be kind of operating with the assumption that kind of consent is the core consideration here, and that, their information won't be shared without their consent, or at least that's the ideal. But actually, a lot of this guidance is consent is important, but it's just one kind of value among many, right? And
that's right.
There are plenty of justifications for sharing information without consent.
That's absolutely right. I mean, and that word is exactly right. Justifications for sharing information, because you can think about them ethically as well as, legally. But legally, I've talked about confidentiality, and I've talked already about, sharing information for the public interest, which is narrowly defined for this, in this way about, serious harm, serious crime, and so on. There are other statutory reasons why, if you tell me something as a doctor, I've got to share it with that information with an agency, a central agency for public health. Think about the information sharing that happened during the pandemic. There were special separate regulations that were invoked for that information to be shared, whether you like it or not.
Yeah.
And there's a separate issue about, opting out versus consent, which is a technical hobby horse that I won't bore you or anybody else with, but right now anyway. But this is the point about the consent thing. 2 points, really. Clearly, there are these other gateways, and they're necessarily there, and they're allowed to be in law. I say necessarily in law because all of the things like the GDPR, for example, in privacy law, allows people, governments, to have access to information. I'm using sort of like I'm pussyfooting around using sort of layish language without going too technical. So forgive me, anybody that knows the actual, the real words of these things. But many of these things are qualified. If the state feels that there needs to be an intervention which is proportionate, a whole argument there about whether it is or not, then these things can be overridden, regardless of consent. Now, consent is clearly, a cornerstone of this, not least of all because it helps inform, in this case, the patient about how information is going to be used, lets them take, a choice if that's available to them, either to engage with that service at all or not. There's a debate about whether honesty is a thing which actually engenders trust or not. I personally think it does, but some people think actually the more open you are about things, the less you're likely to be trusted. That's a whole debate amongst some of our philosophy colleagues, which I find slightly, they'll explain it to me someday, I'm sure. But it's certainly a thing that underpins, the medical ethics side of things, be honest. Yeah. Because then patients will trust you. Again, going back to the no surprises thing too. So the consent is, there's consent, and then where and how far consent can actually take you within that wider framework, and being honest with people about it. I think that's the thing that's kind of missing, really.
Good.
Because, we're not really being always as open with people about actually how widely information will be shared if they engage with the health service.
Yeah.
I don't think there's a nefarious, scary thing.
No.
But it's just a thing that people should be aware of.
Yeah.
So information sharing shouldn't be a big and scary thing. And, I think ironically keeping it secret makes people trust the system less. Going back to what I said about the citizens' jury work, you explained why it was important. People, okay, we understand, just make sure there are appropriate safeguards in place. Whereas, when people find out, as I said before, they were surprised that, person in entity, organization X had access to this information about you that you told, you told them, in the privacy of that consultation room, which found its way to another organization because it had to, then of course people are going to be disappointed. So ironically, I think by trying to, hide it almost, I don't think it's done willfully, but I think more openness can only help.
Yes. So I guess this is kind of, we've already sort of started talking a bit about what's actually happening in practice, but I wanted to kind of explicitly ask you about that. So the second part of your research, I suppose, was when you actually went out and did some interviews with GPs, right?
That's
and
right,
you were
yeah.
asking them how they were making these decisions in practice. Were they making use of the guidance and so on? And what did you find there?
That's right. So that was the second arm of the research. And the idea was to bring together these two arms, see if people were using the same principles or different principles.
Yeah.
And if they were different, we'll talk about the synthesis, I'm sure, in a minute. But ask the GPs in a very open way, tell me what you think about information governance generally and information sharing and how you go about taking decisions. And did it in a very narrative sort of way, because I didn't want to close them down and give them a test about confidentiality or information governance or the GDPR or anything. And I suppose what I found in practice was, not surprisingly, they were all very concerned about respecting patient confidentiality, respecting patient choice, but also very concerned to make sure that they gave the best potential, clinical experience and treatment for their patients too. And they sometimes felt there were tensions there. I found that generally they tended to place more value on the more direct clinical aspects and the information sharing side of things, by which I mean that if they had to take a choice where they were in a position where they had to do something which they felt was right clinically, and that has a set of nuances to it as well, they would say, okay, well, they would override confidentiality to do it.
Yeah.
Not really based on any principle as such, other than the fact that I thought, the clinical stuff is really important and we want to make sure that's right. And sometimes for some of them, it wasn't just clinical stuff, but it was about the relationship with the family. Yeah. Either maintaining that or what they knew about the family and the relationship the patient had with their family would, they would take a decision that was probably strictly against the guidance, is what I would say.
Right. And I think you said that sometimes they were operating with the concept of the patient's best interests.
That's right.
Yeah.
And best interest is a complicated thing, because one of the things about this research generally, and my approach, was to try to identify which concepts are used, work out what they mean. Yeah. Where words are used similarly for different concepts, or where words are used differently for the same concepts. Just unpick what they mean with all the underpinnings. And it wasn't really front and center of my research, but one of those tricky phrases is this idea of best interests. Because in medicine, in law in this country, there is a thing called the Mental Capacity Act, which enables people to act, again, I'm paraphrasing, in the best interests of patients that lack capacity to take decisions on themselves. Yeah. And that's a phrase which is, it's got a legal meaning, can only be invoked in particular cases where the patient doesn't have capacity. Yeah. But day to day, of course, I'm doing it in your best interest, aren't you? I think it's in my best interest to, tell you something. And sometimes, because of that, the way language is used, that phrase best interest, it's not best interest under this bit of legislation. It's just, I'm acting in your best interest. It's not a defense, though, for saying I'm going to take a decision that, to share information about you with somebody else, because it's in your best interest when you're completely compos mentis walking around the place. Because I could have asked you, maybe consent was relevant. I could have got your consent, but I just thought, well, I'm doing it in your best interest. And as a shorthand for, I couldn't get around to asking you.
Well, or maybe a shorthand for, it just felt like the right thing to do.
Well, that's
it seemed like in this situation, I just kind of had to do that and then ask for an explanation of why they did that. They reach for something like best interest, which seems like the most plausible
that's right. I mean,
explanation.
It's a slippery thing because you kind of understand what where they're coming from. But certainly, again, a change in medicine over the years has been, a big move away from paternalism, because what best interest is effectively saying is, well, for whatever reason, and often it was expedience, lack of time, I'm just taking a decision that I think I'm being paternalistic and taking this decision on your behalf because I think it's in your best interest. Well, if you don't have capacity, then that's a reasonable thing to do, because, it's not just my view in that case. There's an evaluation that has to happen as well. But if you have capacity, then surely you know what's in your best interest better than I know what's in your best interest. So it's a little bit paternalistic to do that. How you said, John, take decisions in my best interest, and So that was. I think there's a bit of confusion around that. It needs a bit of clarification for them, I think, actually.
We should say kind of, one of the reasons why this is so difficult is because GPs are immensely time pressured, right? So they get, what do they get, 10 minutes per consultation?
Oh, it varies. Of your luxury up here, I think. It was 7 at one point. I mean, it does vary again, some places,
And already having to make decisions that are in their own right really complex and
that's
might seem of more central to them. And this stuff about information sharing seems a bit peripheral.
That's exactly right. That's what I was saying. We're all about, the emphasis and the value, the comfort zone, frankly, is on the clinical stuff.
Yeah.
Which is not surprising, probably as it should be. And I suppose, one of the other conclusions is, if we recognise there are certain principles that should be respected and communicated to everybody and followed, make it as easy as possible for them to be enacted in practice.
Yeah.
So one of the aims is to make the guidance, I think I might have said this at the end of the last sentence, as usable as possible in practice, so that in this case, GPs are supported in making the decisions that are generally accepted to be, in quotes, right.
Yeah.
And it needs the guidance itself, these normative texts would ideally be, if not written themselves directly, interpreted and then communicated in ways that make it easier for those who have to apply it to actually apply it realistically. As you say, given this time pressure, I'd have to go back and look, and I didn't do an actual workout of the number of pages that the guidance they were supposed to read about this idea of confidentiality themselves. I did a pretty thorough set of searches in order to find what was out there from various different bodies, whether it's the GMC or the various bits of the government or various bits of the NHS, and of course the various bodies of legislation and the common law, and the BMA, which is definitely persuasive about, plus mind each doctor, which have their own specialty association that will have guidance on it, hence all that contradiction or different flavour, but just wading through that on its own. You've also got to read the guidance about, hypertension treatments,
Did you ask GPs how useful they find this stuff and whether they feel supported in making these decisions effectively?
So one of the things that came out very clearly from the interviews is that the GPs felt not well supported in this area at all. There was this very large body of information that they've got to digest about information governance and all these different sources, as well as all the other things about their clinical practice. And it's yet another thing that they need to worry about. And the clinical things, possibly because they were worried about, possibly because of different levels of risk. If they treated somebody inappropriately, that exposes them to an immediate level of, the patient an immediate level of clinical risk in the way that a bit of information sharing breaches, doesn't quite. That's not my general view, but just to say, it felt very different to them. I understand that. So they kind of prioritize what they need to read. Yeah. And I think, as I was saying before, the guidance tended to be quite generic and didn't really say, okay, look, actually, in these circumstances, if you're faced with this practically is what you should do to be the right thing. And of course, this kind of normative text has to be generic to a point because it's got to deal with a wide range of scenarios. But I think there was a real disconnect between what was out there, if they had time to read it, and whether it was really practically useful, almost as a library of guidance to say, look, actually, these are the certain circumstances where you should do this. So do it. And although, philosophically, this might all sound rather superficial. It's all about the sort of the implementation of guidance, normative guidance in some ways. It all has to be underpinned by, well, actually, what is the principle-based approach on which you are, this is my view anyway, on which you're writing that guidance? Are we saying, look, the most important thing is confidentiality. So don't, just as an example, confidentiality and privacy. So don't share anything under any circumstances. Here are the consequences of not doing it. So you need to understand and accept that if you're going to be a doctor. And you need to explain this to a patient. That's an extreme case of the strict confidence. Or more realistically, confidentiality, privacy have limits. These are the limits. You kind of need to explain that. And if you don't, if you go too far and make it too strict, then there'll be harm over here. But if you're too free with it, then there'll be harm elsewhere. Set that out from whatever principled approach you want to take. Inevitably a combination of different approach. We just set it out, thinking
Yeah.
both about, what principles, what they should be. And that's a debate in itself, of course, and the consequences.
Yeah. Yeah. Good. Okay. I mean, we're nearly out of time, really. But is there anything else you wanted to say? I mean, you've already said some stuff, but anything else you wanted to say about how this could be done better and what you'd like to see in practice?
I will say this, the one tiny theoretical thing. So the approach that I took through this research was, is it fair to say novel? It's certainly one of the more unusual methodological bits of ethics, which is often, apologies to ethicists everywhere, proper ethicists, seen as a little bit abstract and looking at, principles that exist as entities themselves in the universe. That's completely, all the ethicists will absolutely hate me. Apologies, but I took more of an empirical ethics approach. And the idea of this really was to look at what normative guidance says, look at what's done in practice, and then to try to synthesize them into something which can guide practice, not in sort of is ought Humean fallacy kind of way, but in a way which is saying, look, actually, what should the principles be? Because inevitably those principles will have some real world consequences.
Yeah.
And how do we then actually understand those real world consequences using to inform the principles? So, what the real world consequences now of principles well or badly expressed might be the wrong ones. That's a different matter. But you sort of look at it from both angles to say, here is some ethical guidance that's meant to say what we ought to do, the important thing being do there. So let's actually see what people do and use that to inform what these principles, how well they're constructed, and also how you implement them. So that sort of little ethical tangent, methodological tangent, I should say, is really about the recommendation, which is have that kind of dialogue and say, look, actually, in the real world, take a concept like confidentiality or take a concept like consent. What are we trying to do? What are we servicing here? Are we servicing something which, are we saying, it is always right? I'll take the extreme cases, just because they make it more vivid, to respect absolute confidentiality in that way that, Hippocrates might recognize, because if we don't, there are these certain consequences, or because that's what doctors are supposed to do, or because, let's take the Kantian approach, that's what the duty is to respect it absolutely. And it's, if we try to universalize anything else, we end up in a nonsense. Doesn't matter, but state that, Also mix it in with some of the practical consequences if we do that, which then might, force you to go down that loop to look at it from these different aspects. Have that dialogue, think about how it can actually be implemented in practice, and then produce some normative guidance that will actually summarize that, rather than just stating, quite often broad, it should be kept in confidence. Not very helpful, because it doesn't explain either the why or the how.
Yeah. Sounds good to me. But I think that's all we've got time for. So, Jon Fistein, thanks very much for coming on.
Thank you very much. A pleasure.
If you enjoyed this episode of Ethics Untangled, please like and subscribe and recommend us to your friends. The podcast is edited by Mark Smith at Leeds Media Services, and our music is by Kate Wood. Ethics Untangled is brought to you by the Idea Centre, a specialist unit for teaching, research, training and consultancy in applied ethics at the University of Leeds. We offer master's programmes in healthcare ethics and applied and professional ethics, and PhDs available full or part-time and face-to-face or by online learning. We also offer consultancy and training services for business and the professions, including help with the difficult ethical issues faced by your organisation, commissioned research projects, and online or face-to-face CPD. If you'd like to find out more about these or any of our other activities, please visit our website at ahc.leeds.ac.uk/ethics.